we're supposed to be talking about our favorite appliances, and there's 4 of us. What is it? Well, there's 6 of us. That includes Elaine and Wendy. Okay, so there's 4 of us that are clinicians on here, and I mean, why don't we start off and just go around the 4 and just give an overview of why we use what, when, like, you know what I mean, type of thing, and share a bit, you know, and maybe some thoughts. If you want to even throw in there in this new COVID environment, I think I'm going to be changing up my usual, you know, stick for a bit. I'm going to be trying to simplify things, and I'll explain why when the time comes around. So who would like to start off?
John, what appliances? Are you still using tap?
Yes, I like a tap. And I've kind of voiced this on previous things, so I'll be brief here, but I like a tap because it essentially provides an anterior discluder, is one reason. The vector of force is, when you titrate it, turns into mandibular advancement. I particularly liked, and I haven't said this, but I particularly liked the tap that I used to get from Allentown, because it was smaller than the other taps. I don't know.
Thermacryl?
Yeah, with thermacryl always. Allentown, Airways has, theirs was large, but it's smaller now. I've had a little bit of hardware problems with them, but that seems to be batch oriented. They, you know, seem to get that fixed. So I like their Acutherm. At least the size of the appliance. I have a tendency sometimes I don't like a dream tap. I don't like that at all. I'm sure there's a place for it in other people's hands, but I don't like that. I do use a Herbst in situations where I feel a patient doesn't want to be locked closed. If I sense that at all, I will use a Herbst. But I do happen to believe in nasal breathing, and so I'll use a Herbst with lip tape, and I don't like elastics to hold appliances in. I think that's an unnatural force. But so if
how do you deal with the jaw dropping?
Yeah. Sorry, what?
How do you deal with the jaw dropping with the Herbst?
Lip tape. And actually,
so when they're sleeping on their back and the jaw's dropping, but they can't breathe through their mouth, you're finding that manages. I don't know the answer to this. That's why I'm asking. That you're finding that manages their supine apnea as well as keeping the jaw closed.
I have to say that I can't verify that without having gone through some sort of testing that looks at posture. I use mostly pulse oximetry to verify that, but
right.
But if they wake up and the tape's still connected, if the tape is still where it was when they woke up, you know that the jaw drop's has not been violated.
Well, let me kind of comment on that. There's a couple of companies out there that make lip tape. I don't use those. I use K-tape, which is the athletic tape that, let me just go grab some a second. I'll be right back. Okay.
So it's an interesting question, Barry. I honestly don't know the answer to that, because I routinely use elastics, and I see that a good percentage of the time I've eliminated the back apnea now. I know that because I use a Knox T3, and it's giving me all that information. However, it never occurred to me just using the tape whether it would also eliminate the apnea on the back. I don't have the answer to that. I've never tried
thought of it either. And I've this assumption that if it's still intact when you wake up in the morning, it's still limited, that it's affected the jaw drop.
Does that mean the jaw hasn't dropped though? I don't know. Will it drop even if it's taped shut? It doesn't have to drop wide open, but the jaw dropping theoretically is causing maybe an issue with the epiglottis moving back and causing airway collapse, potentially, right? We don't know unless we're imaging for that. So, we know the mouth breathing issue, but there's also the potential for the jaw dropping and what it might be doing to the airway. But we don't.
How much
don't
of
have-
that? This goes back. This goes back. So this is interesting. And we'll look at that in a second. This goes back. It's kind of interesting. When SonarMed came to me back in 2007, 2006, 2008, whatever it was, and asked me to speak for them, then they sent me their appliance. I wrote to them and said, "This will never work. The draw's going to drop open." And what's his name called me, Peter DeSully, and said, "Barry, of course it works. I'll send you my research." And I looked at the research and I called Pete back. He's in Melbourne, Australia, and I called Pete back and I said, how is this making any sense? He said, "I don't know. It just does." Once I got the appliance and I started working with it, what I realized was, if you bring the jaw forward 2 to 3 millimeters from where rest would be, centric rest would be, what you call that. So if you bring the jaw forward 2 to 3 millimeters, you alter significantly the potential for the rotation and translation to open. You can't open as far. So I set the rule then for SonarMed, totally on a get. I mean, with no, if you must bring the mandible at least 2 millimeters forward from rest. You shouldn't start edge to edge, for example. Or I mean, just start at rest. If you think that the whole patient has to. So anyway, so controlling that means opening. How far do you have to control it? Maybe the tape. Maybe it's enough in some cases to control it. I don't know. Let's show the tape, John.
So I've tried 3 different types. I'm sure there's others, and I'm not offering this as something everybody ought to do. I'm just telling you what works for me. This is a company called Somnifix.
Yeah.
And they've been around a while. Their product looks like this. It's self-sealed envelopes, and it looks kind of shaped like tape. I've found this will not stay in place very readily, which would address your question. The mandible's probably falling open. The patient doesn't take it off. They just wake up without it. Okay. This is another company, and I don't know if this is a second generation company or if they're actually different companies. This is a company called Seal Tape, and it looks very similar to this. Again, I have not had terribly good luck with this. Let me take one of them out of here, and it's kind of nicely shaped like a little lip. Okay, but this doesn't want to stay on either. It will on some patients. So I'm not, and I'll show you what I use in just a second. So I'm not a fan of elastics, not because I think they can't be used, but you get the retention of the appliance the way you want, and then you put elastics on it, especially if you're using thermocryl, it's not a problem. But if you get an appliance designed the way you want, you adjust it to comfort for the patient, then you need lip closure, you put elastics on it. Now you don't have the retention that you need. I mean, what a mess. So I'm lazy. I choose not to deal with that. Okay. So here's the tape that I use. It's an athletic tape. It's called K-tape. They use it for sports injuries and stuff.
Oh my God. Sure.
I will take that.
Did you say K as in Kim or Kiss?
K is, yes.
Yeah.
And I cut it in half. So I take strips and cut it in half. Okay. And then this can be used for when you take it off in the morning. First of all, what happens is you probably do get a little bit of mandibular opening with it, but the patient never wakes up with it off. Never.
It's strong. It's really strong.
What about facial hair? Like, would it be able to be used over something like this?
Absolutely. Yes. That's the advantage. Yes, absolutely. So you don't have to have.
It looks like you have a mustache there, John. Would you be able to use it over your mustache?
Use this. Yes. Yeah.
Interesting.
And you can use this about 3 or 4 nights. So you take it off. You take it off. And put
you get 3 or 4 nights out of one piece of tape.
Yes. You just put it back on the thing here, and it'll work. I don't have to ask people to shave their beards.
Does it remove blackheads and everything as
I haven't charged for that, but I'm thinking of it. So obviously you can see I've tried some different things here.
I like that. That's interesting.
I'm not one that's real subscriber to chin straps. I don't think we ought to encourage teeth together. But other people do. If you try this on some of your patients, just trust me, this works. Okay.
So the K-tape is a tape that's made. There are physical therapists and chiropractors that use it for athletes. They recommend its use because it'll make you stronger, faster, and have longer, enjoyable sex. It's crazy, the claims, and of course nothing's been documented. They don't have any proof of it, and they sell it in as chiropractors sell it themselves and physical therapists sell it themselves, and there are athletes that it's kind of like that mouth guard that'll put your jaw in a different position. They swear that they run faster and jump higher with K-tape supporting them.
Well, let me make a comment on that. It's used for other things too. It's used for injuries. And I got 4 screws in my left shoulder, 4 screws in my right shoulder, and an artificial knee. I've had some fun throughout my life, and all of it's sports injuries. None of it are automobile accidents and stuff. And this won't help that, but they do use it to tape injuries, and it will support a ligament in a joint during the rehab part of it, so that you can continue being active. I'm not suggesting that.
Right.
But that's how I knew about this.
Yeah, no. I when I had my knee, they gave me K-tape.
Yeah.
And I wasn't.
I'm surprised it doesn't pull hair off though.
No.
When you had to put it on your knee, Barry, did you have to shave your leg?
No.
Or did you put it right over the hair?
I never thought about it, but the answer was no.
No. But I'm surprised it doesn't like painfully pull on the hair. I'm just surprised. I don't know.
It kind of goes with, some people might think this. It comes in a cloth or a synthetic. I've tried both. I like the cloth a little better, but they both work. The K-tape itself from that company, that's a brand name, that's kind of expensive. You can get it for somewhere a little more than half the cost just from Walgreens, just a generic
Does Amazon carry it?
Yes, Amazon carries it. You can order it anywhere. And the cloth portion of it is a little bit breathable.
Okay. So the cloth, I'm taking my notes here.
Yeah, so you don't feel as if your mouth's taped shut. Now, obviously you have to have nasal patency, but I think it will also take a mouth breather. I've experienced this. It will also take a mouth breather, and that does have nasal patency, but they're a habitual mouth breather, and they'll very comfortably breathe through their nose. I do think that the mandibular opening, like if you're in your back or whatever, I think this maintains enough jaw position that if you're in a Herbst, you probably have less of the mouth opening or falling backwards with this than you would without it. But you'd have to try to see. So anyway, it's my thoughts. So
yeah, it's interesting.
Space.
So I've been schooled there, John. Thank you. I've just been introduced to K-tape. I didn't know about it.
I just sent you a link for Canadian tape at $3 a roll.
Wow. For K-tape?
Made in Canada.
$3 a roll. Wow.
Yep.
That's dirt cheap. You can keep a roll at the office, give a sample out, explain to them how to use it, and just give them where they can order it, and they can just order it themselves.
I'll tell you what I have done too. Sometimes if I'm delivering an appliance, and even if I kind of feel that I need some tape, I usually don't start patients off with that, because by the time you're giving them an appliance, sticking it in the mouth, telling them you want to put tape around there, sometimes it's like, really, you want me to tape my mouth?
Yeah.
And then sometimes when they come back, for a follow-up visit and their mouth's dry and this or that, they're doing pretty well, but then you introduce the tape and it's just a slam dunk. I mean, they'll try that tape and call you the next day and say, wow, that really makes a difference.
No, I like that, John. I think that makes sense to step it that way rather than overwhelm them up front. And then they don't appreciate what the tape is bringing to the table if you give it to them all at the same time. But this way, you're giving them the tape as a solution, and they understand the importance of putting that on, which will help to improve their compliance.
Exactly.
Good. So that's it. Okay. Lawrence, what do you use? We need to unmute Lawrence.
Okay, I'm on.
Okay, yes, sir.
In lots of ways, I need to recuse myself because I'm not really doing a lot of sleep medicine. My objective in listening to you folk is to know a whole lot more about sleep, but really fundamentally, the people that I see are chronic concussion patients. And I'm trying to help them to sleep better at night without getting deeply involved in sleep appliances as per se. And so it's almost if I've been a lurker. I know I mentioned this to John before. My experience fundamentally with sleep appliances is my go-to appliance if I have to do it. And by the way, I may do one a year, and it's SaunaMed. That's what I do, and I get somebody has to twist my arm a ton to do it. I've had a number of patients that have seen John, and I wanted to and they've been back, not patients per se, they're more acquaintances, and they know what I'm doing, and they say, well, what do you know about this guy, John Viviano? And then I say, well, this is what I know because I've had the wonderful opportunity to listen to him and to share his gift to me, and so that's how it really works for me. So I really can't give you a whole lot of input, John, about my sleep appliance skills because for all intents and purposes, it's not very much. But I do appliances all of the time, and I make them really small and at midpoint appliances like I learned at Allentown, and I help them to manage the trigeminal signaling that goes on because most of them have hypervigilance during the day and the cyclic alternating patterns at night, and I try to dampen that down sufficiently so that the guys who are working to get them better during the day, such as the physios and whatever, they don't have to dig themselves out of a hole to get them to ground zero, so what they can do during the day makes them more successful. So in my group, I'm known as the night shift guy, and that's what I do. I spend a lot of time with them, my patients, and supporting them, being there for them over a period of time. And then when I've reached maximum medical improvement, then I put them on a monitoring process. It's a lot like what John's does, but I just don't do sleep appliances for whatever reasons. Now that could be maybe because I'm still on that olive branch, but I'm not a way out as in your analogy. But I can't get any busier than what I am, and the way that it's structured in my life. I'm ever so grateful for Barry and Don and John, and it's made me a better practitioner.
So you're up in Barrie. You're up in Barrie?
No, Guelph.
Where?
In Guelph.
In Guelph. Okay, so who do you have around you there that does the dental sleep medicine stuff?
Nobody.
Nobody in Guelph.
No.
Interesting.
Not that I know of. There may be some. Now, I want to tell you about taping.
Yeah.
Now that been using taping for a fair long time for people who I've been working with, and they complain just like John was saying. They were complaining about dry mouth or whatever. I never initially present my appliances with taping, but it's always been something in my back pocket, and it does work. I don't use K-tape, but yeah, and also I use it personally. I find
What type of tape do you use? So
I'm using this plastic synthetic tape that comes in a roll, and but I find that initially I would put a band across the lips and one down in here, and I found that was really effective, and their dry mouth would be eliminated, and for the most part. And I also found that that once they got over the hurdle of taping their mouth, that they were quite grateful for it, especially for the women who have a menopausal dry mouth, and you put appliances in, and you're trying to reduce the trigeminal signaling and the cyclic alternating patterns. I found that there was a role for taping. So I apologize for you. I don't have 125 or 150 appliances to share my pitfalls, but that's where I'm at.
oh, that's great. That's very helpful. Thank you, Lawrence. Appreciate it.
But one other last thing. I am very, very interested in Circle.
Right. So Jeff, is doing a webinar on June 5th, I believe,
Right.
on a Friday afternoon. So
And
that will give him more time than what he had before to talk about it and show us a little bit more about its clinical. And even if you can't make it, it'll be archived online so you can catch it after the fact anyways.
Right. But I'm really interested to evaluate taping, for instance, and have them on Circle to see if it makes a difference. And so then I can come back to you and I can say, this is what we've done. So for me, the jewel of a lot of speakeasies has been Jeff. And it's bringing that to me because I can see that happening in a number of ways. Now, I know it isn't the most sophisticated piece of equipment out there, but it does give me the potential to be able to see how my patients are doing with my pain appliances. And maybe I get enough insight to see some of the other stuff that I can then move on from.
Have you ordered any yet?
No, but apparently I understand Dr. Chin is coming tomorrow night.
Right. She'll be speaking well, she'll be speaking about a whole bunch of different things, products to do with keeping your household safe and your office safe. She doesn't have a lot of experience with the Circle.
Right.
She just happens to be the Canadian distributor, which is why I then asked Jeff, look, do you want to do one on the Circle alone? Right? And he's speaking the following week. So what she brings to the table is basically access to antigen testing and a whole bunch of other things which are kind of cool. She probably won't be able to answer much about Circle. She's a Canadian distributor, but it's not really clear to me between the two of them who you order it from because they've arranged something between the two of them. So, but she could perhaps tell us the answer to that tomorrow.
So Don, I see you're on, and I could ask you this question. Do you find that when you put in your sleep appliances that if they've been REM deprived, that with your sleep appliances that their amount of REM that they improves?
Yes, that's one of the questions I ask if dreaming improves all the time. And that seems to happen more often than not. I don't have a number for you.
So what happens if they
and
say?
I will see REM rebound.
Sorry, Don. This is important. This is important. So what happens if they say I'm dreaming a lot more during the day than I did before, Dr. Malaysia?
During the day? Then it's hypnagogic breathing, and I check for narcolepsy.
I can't always be serious.
But But we know that REM deprivation is very significant for memory loss. And so and memory loss is one of the big things that a concussion patient deals with, a chronic concussion patient. And when concussion patients, for whatever reasons, sometimes all the systems just go crazy. I mean, their ears bother them, and their balance bothers them, and they got their headaches, and I can't remember what I said 5 minutes ago, and but you start to ask them about their sleep patterns, and they're all messed up, and so I know. You're talking about sleep breathing disorders, but there's more than just sleep apnea in this big world of sleep breathing disorders. And it's just a world that I'm more interested in other than sleep apnea. And
Laurie, what's interesting is that absolutely, and unfortunately, what we have is we have really good evidence to suggest that if we hold the jaw forward, we can alter laryngeal compliance, and so the blossoming occurs with sleep appliances, and not only has dentistry spent most of its time. Sorry about that. It's D-man. Not only has dentistry spent most of its time worrying about, the obstructive disorders, but so has medicine. So medicine goes and the sleep center, because that's why, because that's where the dollars are. That's where the dollars are. And the realization is that there are many more things in sleep. And Don and I were just talking yesterday about sympathetic dysautonomias that obviously have sleep components. And unfortunately, because of the controversies with oral appliance designs, if we tried to, as soon as we talk about an anterior midpoint stop appliance having an effect on trigeminal signaling, that's different than with or without the presence of posterior contact. No matter, you can have Vittori, you can have Hasegawa, you can have all the studies you want. There's this emotional response that is created that has prevented us from recognizing the potential value that someone like you can provide to our patients with traumatic brain injuries, as opposed to trying to treat them without that contribution. It's, as you know, not the only contribution. Obviously, there's lots that medicine can do. There's some interesting work that they can do with lights and eyes and all that. But unfortunately, we lose the potential because of the history of empirical evidence and emotion in oral appliance design in the absence of science.
I would take that as a valid comment. I would say to you, having some pain in your temporomandibular joint is one thing, but in reality, if you back up and you listen carefully enough to these people, they don't sleep.
Right.
And they're a mess. And there's all kinds of these operations treating concussion patients, making big money. And it is a joke, because they look at what they see during the day and they don't understand anything about the recovery and regeneration and restoration that's needed to take place through the sleep cycles. And I mean, you guys have now done so many cases that you can see these people who get better. But then the question is the population that you're seeing getting better because they came into your office because without the problems that I'm seeing?
Yeah, we can't even begin. I mean, Don and I will talk about the various patients. We just talked about Suzanne yesterday, Don, who was going through
Goodling.
What?
Was it Goodling?
No. But it's close. But anyway, here's a patient who was Tracy is the other one, the young girl, basketball injury. They couldn't get anywhere, was having migraines every day, etc. And we treated her with an anterior midpoint stop. And then this other one was in a car accident, and she also had all the ear symptoms, all the dizziness, all the vertigo, and couldn't respond to any medication with dysautonomia. And she also had, interesting enough, Laura, she had sleep apnea. So we treated her with a tap appliance. With anterior midpoint stop, and made such tremendous strides that we got calls from physicians like, "What the hell? What are you doing here? What's going on?" And but we don't have. We don't have the stuff. We don't have enough numbers to write anything up significantly or make any proof of that. What we do have, what we are hopeful for, is that people will start doing the functional MRI studies that we're starting to see happen that show the changes in brain signals in certain areas of the forebrain, and that's our hope. But we're not there yet, and we have more studies with migraine that indicate the positivity that we can provide. But again, we're not there yet. And then the problem is that we have those people that help somebody with a migraine, and then they make up ridiculous statements that, like, migraine is a temporomandibular joint disorder, stupid things like that. So it's criminal that we aren't contributing more, while there are those with a knee-jerk reaction that are claiming we can do more than we can do.
So I'm sorry that I sort of hijacked the conversation from appliances, but I just wanted to thank John and Barry and Don because I really got really keen about this thing when I went down to Allentown when they had the forums with Don and Barry. And he was saying, well, let's look at, we were doing cases. And then he pulled out this gal, Tracy. Now, Tracy, I know because he gave me the literature, and I probably look at that every 6 months. And this case, because she was the way that Pennsylvania legislation came up with Tracy's Law, which gave guidance to all of the coaches in Pennsylvania. And we were deeply involved in Ontario when they decided that they had a gal in Ottawa who had 3 serious concussions in a period of a couple of months, and she died. And they basically copied Tracy's Law in Ontario and declared it was Ontario's great contribution to sports medicine in Canada, and it was a pure joke. And so every time I see the Ontario legislation, and I remember Tracy, and Tracy came back in 2014 when I was in Allentown, and we petitioned the Ontario government to not go the regular route of copying, but to come up with creative ideas, but it never did happen. Anyways, that's a sidebar story. And so I'm very grateful, and publicly, although it's in this small group, I'm very grateful.
So we have our Rich Cohen with us, but is only an initial showing here. Rich, is your you in your pajamas or something? You don't want to show us your webcam and speak up? You don't have to. You don't feel any pressure, but we'd like to welcome you into the conversation. I see your mic is now on, Rich. You're actually logged on twice. Yeah, hello? Looks like you're logged on twice. One has your mic on and the other one has your mic off. Let me see if I can unmute you. I don't know. Yeah, it says you're connected and your mic is green. Anyway, I just wanted to invite you to speak and just share with us your favorite appliance and what you like to use. If we don't hear any noise, that means for some reason it's not getting through. Are you there?
Hello, Rich?
So,
Are you talking to Rich Cohen?
Yes.
I got off for a second. I got cut off.
Now, Rich, you can turn your video on if you like. Just click on the little video camera.
while we're waiting, Barry,
Yeah.
could you talk about Amorphous and what special attributes make it better than the present tap attachment?
So I actually have if I have photos of it. If you look at it, it looks like a tap. The hardware is such that one of the problems with the tap, John and I know, and I know you know, is it there was a period of time where they were losing a lot of it would reverse on you from the forces, and you'd wake up and then so trying to it would start to strip. So we eliminated the potential to strip. We put 9 millimeters of protrusion in one attachment in the initial hardware. So the chances of needing to switch out hooks and all that is gone. Because John spoke about the smaller appliance from Allentown. That the only reason we were doing appliances in Allentown, and he still, by the way, is still doing them. The only reason we opened up a lab at all was because of my frustration that Airway wouldn't listen to me and prescribe do the appliance as I wanted it, because I wanted the smaller profile. I could cut it each time, but I didn't want the thing wrapping around the third molars. I don't care what people think. Wrapping around the third molars doesn't prevent open contact. So I didn't want it wrapped around the third molar. I wanted a thinner profile, smaller profile over just to the cervical thirds. I wanted to vary that profile based upon the retention that was available in the cervical thirds. Of course, no lab would do that. And I found the lab that we're making the appliance in, the Morpheus, is actually in Sheffield, in England. So it's thermocryl or triple laminate, 9 millimeters, smaller profile, and cost. It's probably, I don't know for sure, but it looks like it's going to come to the market at about $325. With the same guarantee and etc. So,
what is the guarantee, Barry?
What?
Is it 1 year? 1 year of the guarantee?
I think it's 2. I think it's 2 for parts. You know, we can make it 3. I don't care. You know, it's just that's for me. That's the plan is that there will be an office in my hometown in Florida where everything gets sent, whether it's models or scans, and then we'll scan it there and have it produced in Sheffield and then sent back and distributed. And we can still do that within the 2-week time frame. And then all emergencies and things that we need to get out quickly will be done in the downtime lab, because they're going to be the lab doing. So we'll have quality control. That's the thought process. I don't expect it's going to get. I think there's a market for it, John. I don't know. There's a lot of people who really like the Tap 3, and they're trying to phase out the Tap 3 because he lost his patent to the Tap 3. So that's a lot of the reason, in my estimation. I'm not sure but that's the only reason for the Dream Tap. They gave the reason for the Dream Tap is that more tongue space, but I don't know about you, where they put that attachment. That thing being out front has caused forces, you need to make the appliance more retentive than you would have otherwise had to have made it. So and I found them to be bulky. I don't like John. Moses. I never liked the Dream Tap. So for those people who want what may be a little bit better, a little less expensive, good company making their appliance, I think we'll have a small market. We'll see how it goes.
I'm sorry, keep going.
In 3 months.
I'd like to add something about the distal wrap thing, just out of interest. So there's lots of talk about that, and I don't know if it helps to open contacts or not open contacts, whatever. But in other words, I can't point at any literature that shows that. However, you need to know the brand new Avant appliance by Somnomed does not wrap the distal. And so the US people, some of the top CE providers, basically said to Somnomed, you need to wrap the distal. Like it's going to lead to tooth movement. We want you to wrap the distal. And of course, their design, their software does not allow them to wrap the distal. And basically, Somnomed's answer was, look, we distribute this, as you know, Somnomed's worldwide, around the world, in all these different regions. You guys are the only guys that are asking us to wrap the distal. Us in the U.S. or you guys in the U.S. I can refer to as you guys because I'm up here in Canada. But anyway, North America is the only people that are asking for the distal to be wrapped. The UK, Australia, everywhere else they are, the European countries, nobody's concerned about the fact that it doesn't wrap the distal. Just thought I'd throw that out there.
Yeah, I just had a second molar full gold crown done. It was in great contact. It's now open. Just saying. What sleep appliance do I wear?
Yeah.
None. Thought I'd mention it. If I was wearing a sleep appliance, it would be because you're wearing a sleep appliance and it's not wrapped. So I'm excited about it, just to be, keep me in the game kind of thing. I am the advisor, the quote unquote medical advisor for the company. I will be running all the support. We're creating a web page now. Anyone who orders one can connect with me, and I become a support system for them for their use of the appliance and for their cases. We're hoping that's an advantage. I look forward to helping people. We will create, there'll be a place to contact me via that website or via email. So, we'll see. I'm looking forward to the challenge.
The price point seems very good compared to what a Dream Tap or a Tap 3 costs.
I don't even know it at this point. Anybody know what for example, if you got a Dream Tap from Glidewell, does anybody know what the cost is? Anybody?
I don't know.
Mine were $350, but I negotiated that locally.
Oh yeah. Oh, so that's local. That's not Glidewell. That's a small company. You know. And what Airway did was they long time ago they created they and there was a point in time when Thornton wanted people making the appliances, so he would just sell dentists the hardware. You want it? Here's the hardware. Go make it. And then when he sold the lab to Airway said, you can't do that. Stop doing that. Well, all these people were making their appliances, and labs were making their appliances. We said, okay. And what he then did was, okay, if you're going to make our appliance, you have to be FDA approved. FDA approval is about $4,000 a year. Small labs looked and said, no, I'm not paying that. So he eliminated a lot of labs that were making it. And so the only labs that are making it are DSG, Glidewell, larger labs. Allentown Dental Lab is one of the few small labs that continued to pay it because I wanted the appliance to have that, under, and now, he's still making taps. They're still making taps. He's going to switch to the Morpheus as soon as it's available. So interesting. It's all. It's no better than any other appliance, and it's got all the advantages the tap has and all the disadvantages. It's a form of a tap. But I'm excited about it just because it gives me something to do.
There you go.
There you go.
Don, what's your favorite appliance that you reach for, and just a little overview of why? And
I still like the Tap 3, the original. If I have somebody with limited vertical, the Tap 3 with the original hook, it gives me the smallest opening. I like Somnameds, but they're too bloody expensive. If they were the same price, I would do more Somnameds than I'm doing now.
when you say
Somnamed,
Somnamed, do you mean the dorsal or do you mean the new
the
Avant?
dorsal, yes. Yeah. The dorsal. I want this new one to be around for a while before I try them. I feel like I'm a beta tester for the Dream Tap. I'm sort of pissed at those people. I've had more breakage and more problems with it. I'd smack Keith right up the head for that goddamn thing. I'm pissed at him, actually. It's just awful. And for telling my lab that he would not give them Tap 3 parts. So Airway. I tried to have my local guy order Tap 3 parts. They wouldn't send them.
They're trying to phase it out. They're trying to move to the Dream Tap because in my estimate, I could be wrong, and Keith could probably get a phone call tonight from Keith, because he checks in once in a while, until he finds out about the Morpheus. But he checked I think it has to do with the patent. The fact that he lost his patent. They worked really hard to keep the MDSA out of the United States. In his work with Bird, and he's done everything he could to limit the competition. If you look at the statistics, the work that just came out of the AADSM, when they were looking at all of the products, all the various appliances, and showing large numbers on their studies, if you did a meta-analysis and you took out the Sonomed and the other appliances, the tap seems to be more reliable in terms of efficacy, but I can't sit there and say that out loud. There's a proof of that. But that seems to be the case, and whether that's because the jaw's not dropping. At the same time, I don't think if I were instructing a young dentist today in sleep, I would combat the concept that the AADSM teaches them that you have to be an expert in 37 appliances, in all these appliances, and you have to, and some of the rules that they make up as to when you use certain appliances, some of those it's really phony. I don't believe it. I don't think that any of that's valid. But I do think that that a good sleep dentist would have an appliance that is anteriorly attached, and an appliance that is dorsal type for certain purposes, for the chronic pain patient, for the patient that wants an appliance that's not that they worry about retention, etc. They can't handle a retentive appliance. A dorsal's great appliance, a great choice.
I'd add claustrophobia to that list too, because some patients just are afraid of being locked together.
Right.
Yeah, so
John's laughing.
well, because this is one of those areas that Barry and I are like this on, but that's okay. That's absolutely fine. But it's interesting because saying, I don't believe in that stuff, and then pointing out a couple of issues where, there's this or there's that, claustrophobia, whatever. And this is more to really the fact that the bigger picture is that, there's going to be certain, this is opinion now. That's okay. We're allowed different opinions. There's going to be opinions that are, this is the part where there's the big trunk of evidence, and we're on that branch, and then we have our empirical findings, understanding of things and everything. We're walking off the branch, and you get too crazy and out there, you fall off the branch. So we're trying to sort of like bring some sense into this. Now, the way I teach, I think you all saw the way I teach appliances and the various designs and try and match them up. I'm going to use a term, and I don't even know if I'm using the term properly, patient phenotype, the way they present. So when I have a petite lady come in the office, right? I'm going to try, if I can, if she's a candidate tooth-wise, I'm going to try and use the smallest freaking appliance I can put in her mouth. That's what I'm going to try and use. So if I'm using a dream cap, the Actron body has got the smallest chassis on it by far, very, very, very thin. And so I'm going to, use that. But if she's hesitant to have it, being locked closed like that, well, then I would go to one of the nylon appliances because, the material is very thin, it's very small. And I know, it's interesting, when the nylon appliances first came in, at that time, at that stage of my dental sleep medicine career, I was putting a lot of dorsals in. Okay, and so I went from the silencers to a lot of dorsals to a lot of nylon. Those were the three, and then there was other appliances, little bit thrown in alongside. So when I was changing, people over, like new appliance, time for a new appliance, and that transition of going from wearing the Somnodent, which they had no complaint at all of. They were fine, they were compliant with it, they were wearing it, they were thankful for the benefit it was giving. And then it's time for a new appliance. Well, we have this new appliance now, show it to them. So I'd like that. And we put it in, and it was an immediate recognition. Oh my God, this is so much smaller. So, wow, this is nice, I like this. But you have to see it on their face when they've been accustomed to wearing something that they were fine with. It's not like they had a complaint. But when they had the opportunity to try something so much smaller, they really appreciated it, and it was a win. I can't say it happened very often that we went from something like a Somnomed to a nylon appliance where they were disappointed they went that way, unless we were having issues that happen occasionally. So, I try and use the smallest appliance I can use that the patient's a candidate for. When I say that, with these nylon appliances, whether it was the Norval back then or the DSAD now, you need to have good, solid, bulbous retention on the mandibular molars, or the appliance will just peel off the bottom. So they got short teeth because of bruxine, and there's not a lot of bulbous nature to it. I wouldn't even consider using a nylon appliance in that particular mouth. Right? Now, if somebody, on the same token, if somebody comes in and they have a high supine level of apnea in their sleep study, I'm not going to use a herpes, because the force vectors on a herpes are to push down and forward, promote jaw opening. We say, how do you know that, John? Well, I don't know that, but I know the studies that was done in 2006 in France demonstrated jaw opening tendency with the herpes appliance. So it's the only one thing in the literature that I have, but anecdotally we know that, if you're pushing downward and forward, that's the force vector, kind of makes sense even empirical evidence that the jaw is going to more likely to open, as opposed to an appliance that's pulling upward and forward, like an Emma style appliance, or an OptiSleep, or the new Avant appliance, the same thing. The traction upward and forward, theoretically that would be promoting jaw closure. So I'm going to either use a tap where I don't have to worry about the jaw dropping open, or I'm going to tend to use an appliance where the force vectors from the pulling, or pushing is promoting jaw closure, which would be like an Emma appliance, or the Avant appliance, or even the DSAT appliance, even though that's on the horizontal plane, is not promoting jaw opening. At least it's more neutral, right? So I tend to, I make either a tap or a dorsal appliance, or occasionally a prosomnus. Although the thing with prosomnus is that what I like about the Somnament dorsal appliance is it's a little bigger footprint in the mouth, so that goes against kind of what I was just saying, using a smaller appliance, but it's more forgiving as a result. With the with the prosomnus appliances, there's very small, little contact with the teeth all the way around because it's a smaller appliance. But then it means it has to fit perfectly and it has to have really good solid retention. Otherwise, it's dislodged very easily with lateral movement on those wings. Whereas if you're wearing a Somnament appliance and you move laterally, because it's covering more surface area, it's less likely to be an issue of dislodge, right? So yeah, these are the different types of things that I look at, like the retention available on the teeth, whether we're talking about a petite person with a small oral cavity, or whether we're talking about jaw opening, whether that's an issue because of supine-related apnea. Those would be the main issues. If I don't know, but anybody here placed an Oasis appliance? I placed only a small number of those, maybe a dozen, and it surprises me that they don't complain about the size and the bulk of the thing with all those tabs. But honestly, it looks big when they're having it in their hand and they're putting it in their mouth, but it really just disappears in all the negative space in there, the open space. I don't know about the tongue buttons. Jury's out. To me, Mark, shows all sorts of data that he has on how the tongue buttons help with jaw posture. But the nasal buttons, I think, are useful for sure. As opposed to a nasal strip or something like that to help enhance nasal breathing. So if somebody comes in with poor nasal breathing, maybe the Oasis appliance would be, something to consider. You don't have to include the tongue buttons if you don't want to, right? That's just by prescription. And then of course there's an Optima appliance, which gives you that breathing channel for, supposedly to help people with poor nasal patency. And I've placed only 5 of those. The first 5 that were placed in Canada as their product launch. I've not made one since then, not because I hate it, not because I don't think it works. I didn't notice really much benefit in the 5 patients that I made and using it. And they've only recently moved on to their proprietary straps. Prior to that, when it was first introduced in Canada, it had Emma straps, which I don't like the Meyerson Emma straps because they obviously stretch out all the time and you just never know where the patient is. So, basically, I look at these different things and I try and pick the appliance that is going to be best for that particular patient as they're presenting. That's the short and long.
And as much as I love you to death, John, you just gave a half an hour on totally anecdotal concepts that to suggest that one may be better than another in a certain situation without based on the assumption of how it's going to perform based on its action that we don't really have, and there's nothing wrong with that. All I'm saying is that it makes life, you can go through all that and you may in fact be helping a patient more than you'd help them otherwise. I just don't know that. I know this, that if I keep their teeth together and I don't allow the opening, If the patient doesn't like a big appliance, I can take a tap and go canine to canine for them. They don't have to be big. That I didn't have the advantage. I was one who really saw, and I've seen some of your patients, and I see the real comfort level with the New World appliances. I think that they makes the lightness of that thing and the potential comfort that may be worth the hassle in terms of retention and issues that it can create. And I know that with the tap with Thermocryl, it also fulfills the need for me in my concern with dental changes, and I can easily alter that in terms of the expense of a new appliance, on a patient with a lot of dentistry. And it's in terms of I hear a lot about, you can't use a tap or anterior midpoint top appliance when these teeth are questionable or periodontically involved, and I've never been afraid of that. If the forces are at the long axis of the tooth, that's really not an issue. I don't think there's any more forces on the anterior teeth when there's an anterior midpoint stop than when there's not. All that's that, but I don't, and that's all. That's fine. I just don't think that the practitioner needs necessarily. There was just like 7 or 8 appliances that could be considered, and I think that's a lot for a guy that does 10 appliances a month. I think it's a lot for a guy that does 10 appliances a month, and it complicates it on potentially unnecessarily.
Right. So I'm talking about different appliances and how you would maybe consider this appliance versus that appliance. In my hands, in my practice, I probably use 4 different appliances, right? So, and they all have different feature sets. So I'll use a tap, right? And I'll use a nylon appliance, which would be the DSAD, now that the Norval's gone, right? And I will use
a dorsal of some sort. What dorsal would you use?
Well, a dorsal. Did I not say dorsal?
The Sondermet, Levant.
Yeah. So it would be the Sondermet. Now see the Avant. I'm very stoked about. I've been personally wearing the Avant since December 1st, and I haven't moved on to it. I've got about 2 or 3 other appliances that I got made because of the mini residency that I could try out, and I haven't moved on to them. I've just been wearing this Avant. It's just, I find it so comfortable. It's got the flex lining. It's a very small footprint. It's got that little strap that just lies right along so it's got a smaller footprint on the buccal side, and it's very comfortable on the teeth. So I don't know. I mean, is it more effective? Is it more efficacious? I'm just saying from a comfort perspective, in my mouth, and I've tried so many different appliances, it's a really nice, comfortable appliance. That's all I can say. Now, what happened was it became available to us as of mid-January in Canada because of FDA clearance, and then so I think I've delivered maybe 4 or 5 or 6 in that range there, and next thing you know, it's been March. So I mean, I haven't even had a chance to completely follow up on all the ones I delivered. So so it's not like I have long-term experience with it. The longest-term experience I can comment on is just my comfort, and it's definitely helping. I mean, it's giving me the relief that I'm looking for with an appliance, and I've been wearing it since December 1. So that's all I can say about the Avant. The Avant, the straps are going to stretch out. You're going to have to replace them, right? And that's not necessarily bad because something has to take the brunt of the forces, and I'd rather have the straps stretched out and replace them than have the the teeth or the joints or ligaments or musculature take that, So, really, Herbst, geez, it's been years since I've delivered a Herbst. I find the delivery of the ProSomnus to be so nerve-wracking because, teeth move, right? And those things fit so precisely, and I just find it to be nerve-wracking. I'd rather deliver Somnament than a ProSomnus. Why? Because a ProSomnus is a bad appliance? No, it's just more finicky on delivery because it fits so intimately, and it has to because I mentioned before, very small surface area, so wherever it's touching, it's got to really fit perfectly. Well, teeth move between appointments, so sometimes it goes in, oh wow, that was great, and other times they bite into it and you hear a crunch, and you know a little piece of heart of polymethyl methacrylate is cracked off, and you know what I mean? The patient's eyes are going like this. So, you know, it's just more technique sensitive. That's all, you know, the prosomnus. You know, as I mentioned, the EMMAs I stay away from typically, you know, aside from my experience with the Optima, which was in last year, January, February, March, during that time period there, where I made a few as they got launched. But I have not tried the Optima with their new proprietary straps that they've developed. You know, so I can't speak about them. I just know that the EMMA straps, because they stretch out, is just not a go-to type of device for me. So Barry, you know, basically, you know, to me, it's developing an understanding of what all these different devices bring to the table. If you're going to use this device, consider these facts, but then you're going to pick the devices that you feel comfortable in your hands that you want to use. And, you know, when I jump from device to device, it's because of the different feature set. This one I know, if I use a tap, it's going to keep the jaw closed. I don't know. If the patient will tolerate wearing a tap right up front and not give me a hard time, oh shit, I don't want all that metal in my mouth. I don't want to have my jaw closed. And you see that resistance. I'm always, just like John was basically looking for ways to keep things simpler, right? If somebody's giving me a lot of resistance up front with a tap because of the way it connects them, personally, I say, okay, fine. We'll do it this way here. I may need to add elastics. And Barry, I think may disagree with this, and it's fine. Let's hear both points of view. You know, we may need to wear elastics to keep your jaw closed. This one, I know your jaw will stay closed, and you have a lot of supine apnea when you're on your back, a lot of apnea going on. And so the patient sometimes will say, okay, well, fine. Let's take the one you recommend, right? But I got their buy-in. For me, it's important to get their buy-in, rather than, you know, like to have them, you know, if they're bitching right up front about that jaw closure thing and not being feel claustrophobic, I don't want to find out after I've made it for them that I have to remake a different style because they're just not going to wear it, right? So I can take care of that patient with it being locked closed, or with another appliance with elastics on it. Or John Bosey's just taught me today about this tape, and maybe that could replace elastics. I don't know. I'm going to try and find out. So when the opportunity comes up, I'm going to send somebody home with a HST, and I'm going to have them go home with just the tape on and just elastics on. And we're going to see if we get the same results with just the tape. It's going to document that with sleep studies, and we'll see. I'd be really interested to see if that's the case. Then people have a choice, you know.
Do you show someone more than one appliance and allow them to choose it?
Okay, so this is important, because if you show them too many appliances, now understand something. I work in an environment where people are paying most of the time out of their pocket, right? And people, when they're paying for something out of their pocket, it's discretionary spending in their mind, they like to know they have a choice. This is the psychology behind it. So I really don't like showing them one appliance and saying this is what you need and this is what it's going to do. I like showing two appliances. So I'm going to have, my first choice for you is this tap appliance, because it's going to keep your jaw closed when you sleep, and blah blah blah, and some other features. However, another alternative is this one here. However, if we do that, we may need to have elastics on there. And you know what? And I see this all the time in their eyes. They're going to say, oh, fine, no, I'm going to take the one that you recommend first choice. Those patients are going to just go that way right off the bat, and that's great. I get what I want. I get them to use the one I've recommended as first choice. But I like to give them an out, because if they're at all claustrophobic or they're going to have an issue with this thing, I would rather use an appliance they're going to feel, because I'm speaking to the compliance part of it here. I know either way I can take care of the thing, but I'm speaking to the compliance. I want to make sure I get their buy-in and they feel good and that they had a say in, you know, in the product, not just, you know, being forced, something being literally rammed down their throat. So that's just my personal approach to this, and the reason is trying to be considerate to the psychology of the patient, their needs, their need to be able to have a little bit of a say, get their buy-in. But I'm only going to be showing them appliances I feel I can do the job of. There are times when the issue is so so limited because of their dentition and they got a really bad supine thing, I would just tell them, look, at the only appliance I'll recommend for you in your particular situation, and these people will know that they have a very serious problem, right? Will be like and the tap is my go-to appliance if you're wondering, for that tap design for people that have a very severe supine apnea, right? And I have patients over 100 events per hour managed with that type of anterior connector. So I feel more comfortable and more confident dealing with the severe stuff with the top than I would with a dorsal or with a DSET. Not that those are bad appliances, but it helps to manage the jaw drop issue without question.
So let me respond to that. First of all, I don't think it matters whether somebody's paying for it or whether someone has some insurance. The buy-in that you need from them is the same. So I don't feel any different whether I've got a full coverage or and the patients are fully insured, or whether the patients are paying for themselves. I don't feel any difference in the responsibility to them and their decision-making process. The second thing is that I find that if I think, while it may be a little different because of a comfort issue, I didn't go to my orthopedic surgeon and he didn't show me 3 different knees that he could have that he could use for me. He took the one that he thought was the best for my condition and showed me the mechanics of it. I have found that patients will be making, if you give them choices in my own mind, what I'm saying is that patients are going to make a decision based on some emotional component that's not in any way, shape, or form related to reality. They make a decision on color, they may make a decision on size, they may make a decision if you vary. I know you don't, John, but some doctors say, well, this is this much and this one's this much, so they may make an economic decision. They may make a decision based on how they think it's going to feel. And I always warn docs when they tell me that, well, they know that this one's more comfortable because they've had them both in their mouth and this one's really comfortable, that I warn them and say, well, that's because it's more comfortable for you doesn't make it more comfortable for somebody else. Or because we give them an appliance, they've had one appliance A, and now we give them appliance B, and they say, well, this is more comfortable than the first one, that therefore, but the first one was comfortable enough and they wore it, and that's really obviously what matters. So what I would do with regularity is that I was comfortable with tap being my primary. I had a tap that I showed them, and one that they put in their hands and they touched and looked at. And then I took another one and I put it in my mouth. And I showed them it go in. And now they see the size. Yes, they see my teeth are together. They see that. And was there a patient that said, oh, wait. Your teeth are together like that? You keep your teeth together? Yeah. Oh, we have options if you'd like that. Oh, no, I could. Fine. I'm all good. But they see it, and without me raising that as an issue, they see it, they've touched it, they've seen it, they see it in me. They go, oh, and 95% of the time, we were done. That was it, and it eliminated that whatever them being involved in it. And I still think they had the buy-in. They saw it, they were comfortable, but they didn't have a choice. I was afraid that they were making based on concepts. Now, by you saying this is the one I recommend, literally, John, I think we're doing basically the same thing. And then,
right. I was just going to say that I think that we end up with a similar result.
Right.
Because I actually am giving them guidance as to my first choice. I just like having a choice myself, and maybe that's my own personal bias. So I like to extend the same courtesy to my patients. And I think in an environment where people are paying for it out of pocket, it is different than people where third parties paying. Well, you know what? You've got medical coverage. This is a device you need. It'll take care of your problem. People ask fewer questions when a third person's paying for something, and they're less anxious about spending that third person's money. In an environment where people have to reach into their pocket, I think the psychology does play a bit. And when they feel they have some say, even if it's directed say, like I'm giving them 2 appliances I think will work, or I would never even be showing it to them, right? But they feel that they've had a say in it. I think that helps us close those cases. That is just pure opinion, anecdotal, talking about that insurance-free environment where people paying out of pocket. That's
Don,
all.
you want to address that? Give your experience. Don, you have to unmute.
I'm
yourself.
sorry.
Any thoughts on that?
Don probably wasn't
apologize. I was
listening.
looking.
So just so you know, for the last 20 minutes we've been talking, and Don has been doing research and looking and putting more literature in our EndNote. He's paying literally no attention, and we have caught him. Just so we know. How'd I
That's
do
okay.
that?
So you were talking about recommending a
The
tap.
patient choice or not?
So
My
all this
routine
means is
is
that tonight I've got more fucking reading to do. Thanks a lot.
you're welcome. My routine is the tap is sitting there on the consult table, and
Right.
I don't bring anything else out unless I suspect something's different, or I've had it happen twice in the last 5 years that somebody has said, I'm claustrophobic, I don't want to be locked together. I actually had 2 people say that to me.
And to be totally transparent, this isn't a surprise. Don worked with me for 5 years in my office and went to every
Right.
consult. So,
Right.
you know, that's the
But
way
I've tried other appliances. I've done Oasis, I've done Herbst, I've done multiple Somnameds. I've had patients come in and I've tried to handle, what was that crazy one from Greenberg?
Z-Pop Plus.
Right. I mean, I've dealt with them all.
Z-Pop Pro. Z-Pop Pro.
Yeah.
An appliance will break in time. I have my tap made right down the road. I can turn it around really fast. The Somnomed breaks, the patient's without it for weeks. I don't know what it's like with, I guess with the ProSomnus, they could just crank one out for you right away. But to me, you know, I can repair most of the tap problems myself.
Right.
It's just, it ain't broke. I ain't going to fix it.
I know. It's the other way.
I'm sorry? Yeah.
Yeah, that's right. That's nothing.
I was going to say, it's getting to be almost 10 to 5. I see Claude. It's amazing how quickly this time goes. I thought this was going to be over in 40 minutes today. You know, but
John, there's a question from Rich Cohen about vertical.
Right.
Just my thing with a tap, I can add vertical. You know, I can remove the titration assembly, add acrylic, reattach it. Sometimes I can bend the bars. So vertical isn't a big issue. I also like the tap.
So,
that
but
if
what's
I have
the
to get rid of
question?
vertical,
What's the question Rich is asking? I can look.
What about the ability?
Well, I was asked, you want
Yes, please, Rich.
an appliance where you can add vertical when you need to. It's an essential component, vertical and forward.
Okay, so because maybe we'll take turns responding to that. Rich, I always have been a big proponent on vertical. Others aren't. I wish all appliances were adjustable vertically along with, anterior posteriorly. Unfortunately, it hasn't gone that way. A lot of that has to do with most of the research that has been published has been about advancement and very little research on vertical, and even the stuff that's published is conflicting. So, what I know from personal experiences and empirical evidence is that a subset of patients benefit from a different vertical. So how do you know who that is? We had Don Lewandowski on one of these sessions earlier on, and he talked about how he phenotypes patients where a larger male with a scalloped tongue, he recommends more vertical, and then, medium-sized vertical, then smaller vertical for a petite lady, and that would be a range. And so he's done some studies, small n numbers, showing that, that this plays out, and so I've been phenotyping my patients like that when I take my initial bite. Lately, since December, so just a few months before we shut down, I've been using the Apnea Guard Reimagined, where I can scan the bite and then send off for the patient the appliance and have the patient continue wearing their Apnea Guard as an appliance. They're adjusting forward while they're waiting for their custom-made appliance to arrive. And then if they've adjusted themselves forward 3-4 millimeters, whatever, I then jump that setting to the custom-made appliance. So without missing a beat, it's as if we initiated therapy the day we took impressions. So I've been doing that since December, but then as mid-March, everything shut down. I'll go back to doing that when I get back into the office sometime in June, and I'll be going back to that protocol, and we'll see how it plays out once I have a reasonable N number. So what that does basically is I use a different tray height depending on their phenotype. Now, you don't have to use the EpiGuard system to phenotype that way. You can just take a bite using any of the gauges out there at a higher vertical if it's for a bigger guy, or a smaller vertical if it's a more petite lady, and everything in between. So that's my answer to that. Perhaps Don and Barry can chime in here.
The point is absolutely, we've been waiting for the appliance, and having just finished working with a company that actually makes the appliance, I will tell you that the concept of adding the ability to alter the vertical readily in the hardware is obviously more difficult than it would seem. Otherwise, everybody would do it. And it just added so much required vertical. It just became an impossible task. One of the nice things about a tap is that in your own office, it's very easy. We use, instead of the receptacle, our go-to for the Morpheus will be a double bar. And so it's very easy to raise that double bar with acrylic and increase your vertical. So, but it's an lab procedure, and it's not something that you simply titrate with an adjustment screw. Yes, it is that. So we can do that with if you have a Somnomed dorsal, like the normal classic, and you put an anterior midpoint stop appliance on it. Now it's easy. You can take acrylic and add to the anterior midpoint stop and increase the vertical when? Well, the only time the vertical will take place, that increase takes place, is because the vertical is determined in a dorsal, not by the appliance, but by the musculature and rest. And the only time the appliance plays a role in the vertical is when the elevators contract. So you can prevent significant reduction of that vertical during the parafunctional activity by increasing the vertical dimension of the excluding element easily. That's really easy to do. But when it comes to now doing that with a DSAT appliance, no, of course not. That's not easy to do. Doing that with an Oasis, no, that's not easy to do. So any of the routine appliances don't alter vertical. It's hard to alter vertical routinely, which makes it more difficult when you come to the end stages and you say to yourself, boy, would I like to increase the vertical. It's a good point, Rich. It's a great point. And you would have thought that by now there would have been an appliance that could have done that more readily, but there isn't. So when you say can you increase the vertical, the answer is there is no appliance at this point that you can titrate the vertical the way you can titrate the AP.
So Barry, let me just point out a couple of things. With Oasis on the upper tray, just like you're adding your anterior midpoint excluding stop, you can add some acrylic there. Well, if you can tripod, contact at the back and at the front on the upper tray just by adding some acrylic the same way, and then actually increase the vertical for that patient if you wanted to. But it's finicky. You have to sit there and add the 3 tripod, make sure it's balanced and so forth. Right? It's not simple. It's messy, but it can be done. With the DSAT, they have little nylon inserts that you can place in between the upper and the lower appliance, and you can layer them. They come in 1, 2, or 3 millimeter sizes, and you can actually stack them, to get as much vertical increase. Now, it's just another little component in there. It'll irritate some patients, and other patients won't mind it at all. And I can't say that I often resort to changing vertical after I'm done, but I'm thinking that probably is because I phenotype the patient at the time of taking the bite. Even before I've been using the EpiGuard recently, I've been phenotyping vertical for the last 4 or 5 years, where giving a bigger guy more vertical and a more petite person less vertical. So going in, I think you stand a better chance building your appliance that way. But that is purely anecdotal, empirical evidence based.
Well, what I was looking at is that where you're having a hard time closing the pipe, go for a little less more vertical. Same thing with the person that's actually designed after they're having a problem, solve that problem for
Sorry, Rich.
with the posterior open bite or.
Yeah, sorry, Rich, you're cutting in and out.
Can't hear it.
Yeah, you're cutting in and out. Just try again with the main point, see if we can catch it.
Or type it and let Don and read it. We'll read it.
I'll type it in.
Great.
Oh, okay. Yeah. Meanwhile, while Rich is typing it in, Cloud Williams Jr., I see your name here, your videos. You're welcome to turn your video on if you want, or chime in. Is there anything you'd like to share with us about your appliance of choice and why you use it? Your favorite appliance?
Thank you. I guess I've just been on an academic journey for the last, number of years, taking courses, trying to transition to finding a point where I can actually treat patients. So I've appreciated all the information that I've gotten. And a quick question you off. I've been offered the opportunity to work with a sleep group just to provide appliance therapy to their Medicare population. Are there any recommendations or thoughts that I need to know going into this endeavor?
Where are you, Claude? Where are you?
In Dallas, Texas.
Okay. So, first of all, let me tell you something. My advice, and I hear this, Claude, I hear this all the time. I've had people take my course 3 times. And on the 3rd time, I said to them, what the hell are you doing? What are you doing here? Why are you here? He said, well, I need to take your course just one more time because then I'm going to be ready. And I said, you're never going to be ready until you do it. It's you can read, it reminds me of, I won't say it, but there are things that you can learn, but until you actually are participating in it, your book learning, I am telling you, you are ready. You are ready. And you have this great opportunity to work with a practice that's fabulous. The answer is yes. It is more complicated to get Medicare approved. So you've got to, you should be making those steps right away and applying for Medicare approval. And then you understand that obviously there's certain appliances that are PDAC approved. And those appliances include the HERP and the TAPS. All right. So you've got to be, is another one I'm missing? The OASIS claims now that they are.
Well, interestingly, the Optima got on the PDAC list just a few months ago.
Yeah.
And I don't understand how that happened, but I think maybe they're opening the floodgates on that. I don't know.
Yeah,
I mean,
maybe.
it's up to
So you need to, and then the real lesson that you've got to work is how to apply and deal with Medicare. Medicare in the Texas area does very, very well. It pays fairly well. There are a lot of really, and I will tell you that my sleep docs, the dentists that I've trained or worked with in Texas do really well. I don't know what it is about and especially in the Dallas-Fort Worth area. They really, there's lots of good opportunity. So the fact that you're in with an office already, that's great news. That's great. Take advantage of it. And I would suggest connecting with Glenine Varga. Glenine would be great to help you with your insurance questions, because that's your next step. You got to go that route.
Thank you so very much.
I have a question for you, Claude. Are you Medicare approved now?
I did send in my.
No, I'm going through the process of doing the application now.
Right.
Yourself or somebody else doing that for you, or?
Well, I've been working through it. I'll go ahead and mention name. I'm Rose Neerman.
Okay. That's fine.
Here's why I ask you that, and you probably know this. With COVID-19, they've really streamlined that. There's fingerprinting, Medicare has waived the fee to become a Medicare provider. And so there's great incentive. They're getting that. It took me 11 months. They're getting that approved now in 30 days.
Wow. Okay.
So urge them to, Nearman, to get that process done for you. It'll be easier now than later.
Very good. Okay, great. Thank you so very much. Appreciate it.
John, I texted you what Rich typed.
Yeah, open. So I'm just reading your text here. Open vertical in patients
So I put
who
my-
are.
There we go.
I'm sorry. So I'm assuming this means open the vertical in patients who are getting posterior open bite or TMJ pain when too far forward, when they're like very advanced. I'm assuming that means. So he's suggesting to open the vertical when you're dealing with TMJ pain, end up with open posterior bite, or yeah, those two things. Am I correct there, Rich? Is that what you're suggesting?
So here, what I
Yes,
get
that's
is,
where we find it's useful.
what I get is, so if the patient's out too far, if I need to retrude them, and then in order to maintain their gain with
Right.
increase the vertical, and I had to bring them back because they were developing either a posterior open bite or joint pain. I will tell you, Rich, that in my experience, take this for what it's worth, it's very rare that a patient has either joint pain or posterior open bite because they've been brought too far forward. I don't think, in fact, I think that now this will vary from patient to patient, but by bringing them back and opening the vertical, initially, there's reason, and I can explain it. It's going to take too long. That we would incur a higher potential of joint pain with increased vertical than as opposed to bringing them forward. This is not to say that certain patients, just by altering the position of the mandible and the force vectors during the parafunction, won't get better than when they've already developed some joint pain. So if you found that by bringing them back and opening the vertical has helped them, there's a reason for that. And certainly in terms of joint pain. I don't know. I can't possibly explain the sense that the vertical, that the posterior open bite is going to increase. Don, you want to address that? Do you think that there's any relationship between forward posturing and development of posterior open bite?
I can only go by my experience. Going back to 2004, when looking at your cases, the only ones that had posterior open bites were the ones that had posterior contacts on the tap.
I know.
I haven't had one in the last 5 years.
Right. And we stopped seeing them when we went pure anterior midpoint stop. So, Rich, what appliance are you using, kid?
I use a variety of appliances, but mainly the tap appliances, some the mid, either the dorsal or the herps type. You know, we use a whole bunch of them. So I think what you mentioned about the posterior stop may have something to do with it, because we've been using the posterior stop. So we'll look at that. But if you can, lateral pterygoid stenting is a very strong component. If you have somebody forward, that lateral pterygoid goes into some kind of contracture, and it's very hard to get some patients back. Posterior open bites are from lateral pterygoid function, period. And so if you have somebody too far forward for them to respond, then that lateral pterygoid gets stuck out there, and that's why you use lateral pterygoid stretching to get them closed. But I'll try the posterior stops more. I get rid of the
lateral pterygoids actually, that's, I understand that theory. I don't know that that's the in fact the the mechanism. We don't know. It makes sense. I understand that. I'm just not convinced.
Well, I just finished a literature search that shows the Botox and the lateral pterygoid has a great effect with that. So yeah, it needs more, but I have a lot of references.
Okay, that's interesting. I haven't seen it.
On,
Don, you have that?
On the ability to stretch the lateral pterygoid to close the posterior open bite. And
so we have a question, Rich. Listen to Don. Okay.
Rich, can you post a reference for that? I haven't seen that.
The Botox to the lateral pterygoid.
Yeah, I'll get you the references for AAOP and the American Headache Society are doing a joint study together on Botox in TMD and oral facial pain. So as we're getting more of those, I'll send you some of the references on it to show that, you know, I don't have evidence-based literature, but think about it. Lateral pterygoid is what keeps the jaw forward. Relaxing the lateral pterygoid allows it to close. Doing lateral pterygoid stretching has closed almost every posterior open bite I've gotten. So it's just clinical experience like what some of you have said, but I'm pretty convinced that 99% of posterior open bites are lateral pterygoid related.
So Richard, the lateral pterygoid injections are EMG guided then, I assume.
Not necessarily. It's almost impossible to miss it. The research shows that they're EMG guided, but if you go into that fossa area and you back off the lateral pterygoid plate, you're in the muscle. And I've done a lot of them without guidance, but
well, geez, Rich, I'm not convinced of that because the Australians in every paper they've done on lateral pterygoid said that all the early ones that did not use EMG guidance for the needle electrode could have been in the temporalis. So I'm not convinced.
The original Mahan studies, we know that he was not in the pterygoid.
Well, it's better to use that. All the research that I've got shows EMG guided. There's no question about it, and that would be the best thing. It would be the best thing. I'm not going to argue with that.
Okay. Well, that's interesting. I've never thought of. I mean, I've always thought that the mechanism made logical sense, but I wasn't totally convinced that that was related. But it may be. I don't know. I don't know any better. I don't know.
What do you think is causing the posterior bite? What causes a posterior open bite?
I don't know.
Yeah, it's lateral pterygoid. Trust me, it'll come out in evidence-based research.
But some of it could be neck posture, though, too. I think there's a combination. I don't think it's pure lateral pterygoid. I think in some patients you got more than one cause.
We know that the anterior open bites that people claim they get with, you know, or that we do in fact potentially get with anterior midpoint stop appliances, those anterior bites that people claim are super eruption are not, because we've tested them and we've taken models and looked at hundreds of cases and seen that there's no super eruption. And that is, in fact, Mariana Roccabato was in our office and worked with us and showed us where when patients were in anterior midpoint stop appliances, and therefore their posture changed during the parafunction, we without fail, in so many cases, wound up with altered a case from increased lordosis from a kyphotic neck.
Well, he and I are talking at 3. I've got a phone conference with him right after this, as we're going to go design some research to show that relationship. I'm not convinced because the NTI appliance anterior open bite, to me, well, it's a question mark. But yeah, so I'll talk to Mariano today. We're talking.
Great. Well, tell him, please send him my love, and remind him that, you know. And so when he was in our office, we looked at that. And we looked at a case after case and found cervical lordosis. So you say you're not convinced. What do you suspect that anterior bite is?
To me, it's anterior intrusion.
Well, so well tested.
Some of them are. I don't think the majority of them are by any means.
If you look at Welkhouse, look up the Welkhouse study, who suggests it's not. It's interestingly. that study will indicate that it's not possible. That you can't have intrusion from an appliance where there's the amount of contact that there is at night. There's not enough intensity or duration to create the intrusion.
Well, those are really good points. I'll talk to Mariano about it. The bottom line is you're correct. We need to find out what it is that's doing. It's a lot more complicated than what we think.
Here's the good news, Rich. Here's the good news. It's not happening nearly at the level when we started in the late 1990s. We dealt with a lot of them, and it's just not happening at the level that it was. And Don and I will think that we think it's in some cases because of the anterior midpoint stops and the lack of and the altered EMG during the power function. But I can't say that because I don't think it's happening to my friends that aren't using anterior midpoint stops as much. So I'm not sure what the appliance design changed. I'm not sure what's happened, but we're not seeing it as much as we did. That's for damn sure. So that'll be
But
good.
I can tell you for the posterior open bite, all closed for me with a lateral pterygoid stretch without doing anything to their neck. Over 90%, pure lateral pterygoid stretch. So, and I've lectured on it to some of the different national meetings and shown cases. So there may be a cervical component to posterior open bite, but we need an evidence-based study. But there's no doubt in my mind, and I'm a naysayer. I do journal reviews for a couple of journals, and I'm an evidence-based person. But the lateral pterygoid is the master of posterior open bite. It's not mainly cervical, but you can eliminate cervical from anything with the jaw. I agree.
No problem. And it would make sense if that were the case that the anterior midpoint stop altered that because of the, it's interesting. We know that we decreased anterior temporalis by 75% and masseter by 50%. But if you say to me, what do we decrease the response from the depressors by? What percentage? The answer is we don't know because we can't measure. It's not measured. We haven't been able to measure.
The anterior stop will stretch the lateral pterygoid. It's perfect for that.
Say it again. I'm sorry.
I don't know if you heard it. An anterior stop will definitely stretch the lateral pterygoid. So as long as it doesn't cause compression in the joint and cause joint pain, then there's nothing wrong with it.
We can talk about that at length, but it doesn't cause compression in the joint. If you look at it doesn't. The forces aren't. If you've got significantly less forces, I question how it can cause more compression in the joint. But that's another talk for another day. Okay.
Well, thanks for joining us, Rich.
Exactly.
Appreciate it. John, did you have something you want to say?
Yeah, just I want to cycle back just very briefly to what we started this conversation about 2 hours ago. And this last 10 minutes is really really interesting because this is a pretty vocal and opinionated group, which I think is kind of the attraction to it. So, and I'm not exactly sure what you and Barry were talking about as being concerned about people that are going to speak on this, but I would think that anybody that comes to this, or you're invited to it, or has something that they're marketing or selling or whatever, if they're prepared to know that they're going to be asked a lot of questions, there's going to be some people that know quite a bit about this and are perhaps strongly opinionated because of their experiences. I think that this would be a platform to welcome those people to, because then other people could glean from the comments that occur, positive and negative, regarding that. I don't know if that makes much sense or not the way I said it.
No, it does. Yeah.
I think it would be valuable to the sleep community for me to say that.
Yeah.
All 5 of us.
Yeah. Well, we got to find another time. So going forward, I'm going to be sending around an email, including everybody that's been on all the previous sessions, to get sort of an opinion. Take a little survey on when would be a good time to transition to. This 3 to 5 has been good over the last couple of months, but clearly now that people are getting back to work and into their office, we need to find another time, and perhaps not weekly, maybe once a month. A couple hours we can get together once a month. The question is, what week what day and what time of the day. So I'm gonna send a little email out, getting us a consensus on that. And so we don't have any future dates posted right now. This was the last session that we had posted, but we will be posting the topic, which will most likely be the one that we were talking about earlier, and the date and time after we get a consensus back, and maybe in a few weeks in June. But I know myself, I'm going to be busy getting back into the office and setting things up, and other people are doing that. And I've seen the number go down weekly as people are starting to get back to work. So the afternoon on Wednesdays is probably no longer workable for a lot of people. So when you get the email, please respond with an opinion as to what would work for you, and we'll try and accommodate as many people as possible.